Hopefully you guys can all see that. So what we're going to talk about is congenital heart disease. So here's the playing field. This is what we're all supposed to have, which none of your children quite have. But two pumping chambers, the ventricle on the right ventricle and the left ventricle on the bottom, and two collecting chambers, the right atrium and the left atrium on the top. And what happened? And we're going to talk about congenital heart disease, not acquired heart disease. So acquired heart disease is what the adults get. Diseases of the coronary arteries, which are the little blood vessels that supply the heart muscle themselves. They get blockages in those coronary arteries, and they get acquired diseases of the four heart valves. And those are usually problems that are either genetically predisposed to, or they're environmentally induced, meaning lifestyle, tobacco, diet, lack of exercise, and associated diseases like high blood pressure, diabetes, and cholesterol can contribute to all those sort of things. Congenital heart disease, on the other hand, are things that kids are born with. They're structural problems of their heart. They're incredibly common, as opposed to what most of the lay public thinks. Heart disease in kids is about 1 in 100 live births. That amounts to about 40,000 cases a year in North America, and it's still pretty severe. A quarter of them present in the first year of life. 5% of kids don't make it past a year. It's one of the leading causes of neonatal mortality still until this day. And worldwide, we're lucky in North America, but worldwide, 95% of kids don't get treatment for congenital heart disease. So parents often ask me this question, especially moms: what did I do wrong during pregnancy? Was this my fault? And the answer categorically is no, you did nothing wrong, and it's not your fault. The heart develops very early on during gestation. It starts as a tube by a couple of weeks, and it undergoes this complex rotational procedure. And by 50 days, the heart is pretty much formed. So you barely know you're pregnant, and the heart's already formed. And that makes sense if you think about it, because the heart is the organ that's going to drive development of the rest of the fetus in utero. And there are 1,000 things that can go wrong. This is a very incomplete and brief list of many of the diseases that can affect the heart in utero. Now, the other thing that's interesting, at least for me, is that this is a very new specialty. Even in the late 1800s, this famous Sir William Osler basically came up with this great quote: children with congenital heart disease should be treated only for their symptoms. Parents should be advised to keep such children warmly clad, essentially meaning there's no hope for these kids. And really, it all started, interestingly, there's a lot of Canadian roots to it. Maud Abbott was an anatomist at the Montreal General Hospital, and she studied the anatomy of the heart and had a whole library of specimens of heart disease. And she's the one that figured a lot of this stuff out and published an atlas of congenital heart disease as early as 1936. She actually has a stamp that the Canada Post made in her memory in 2000 called The Heart of the Matter. And surgery for congenital heart disease is very new. It's less than 70 years old. And it's really only been in the last few decades that technological advancements have made it such that now nearly all congenital heart lesions are amenable to operative therapy. So this all started with the surgical ligation of a PDA, or a patent ductus arteriosus. That's the purple structure in this slide. The red is the aorta that comes off the left ventricle, and the blue is the pulmonary artery that comes off the right ventricle, and the PDA connects the two in utero. And a lot of your kids that may have had critical heart disease when they were born were put on this medicine called prostaglandin, and that was to keep this PDA open because it normally closes within a couple of days of birth. But in some kids, it doesn't close, and it needs to be tied off. And that was first done in 1938 by this guy, Dr. Gross, at Boston Children's Hospital. Dr. Gross was actually a resident at the time. He wasn't even a full-fledged surgeon. And his boss, who was the head of surgery at Boston Children's, named Dr. Ladd, said to him, I guess residents had a lot of liberty to independently operate those days, and he said, don't operate on that little girl's patent ductus. She'll die if you try. So Ladd left town, and this is the quote from Gross: Ladd was out of town. That's why I chose that date for the operation. I knew he would never give me permission. and I purposely didn't ask for it before he went away. And then congenital heart surgery was born. Then came the blue babies, tetralogy of Fallot, which is a disease in which there's not enough blood flow to the lungs because there's a restriction of blood flow between the right ventricle and the pulmonary artery associated with a ventricular septal defect. Those kids are blue, and all of them died by the age of a year, except for some of them. And Helen Tausig was a cardiologist in Baltimore at Johns Hopkins Hospital, and she figured out, these are back in the days when all she had was a stethoscope in her hands, no ultrasounds, no CAT scans, no nothing. She figured out that kids that had a PDA, in whom the PDA didn't close, they lived past a year. So she went to this now famous Dr. Gross at Boston Children's Hospital and said, can you build me a PDA? Because if you can build me one, I think you can help these kids live. And he said, Madame, I close ductuses, I don't create them. He totally blew her off. So she went back to the surgeon at her own hospital, who was Alfred Blaylock at Johns Hopkins Hospital. And Dr. Blaylock had a lab, and in that lab he was studying
I will have to come with me to school pick up
pulmonary hypertension. Pulmonary hypertension is when there's high blood pressure in the lungs. And the guy that was doing all his experiments was Vivian Thomas. He was a black guy, and a black guy in the 1940s in the United States didn't become a doctor because of race, but he was a brilliant guy, and he created this model in dogs to induce pulmonary hypertension by sewing one of the blood vessels from the body to the blood vessels of the lung, which was then named not a Blaylock-Thomas shunt, but a Blaylock-Tausig shunt, or a BT shunt, which is how blue babies started to get treated. And this is a picture, a real picture from the first baby operation in 1944, when closed congenital heart surgery really started. And Blaylock really, he traveled the world teaching surgeons how to do this operation. And if you're interested, there's a movie called Something the Lord Made that describes the relationship between Blaylock and Thomas and the invention of this operation. It's on HBO. And it's a really fascinating story of congenital heart disease and America and all the rest of it.
Hang on.
Then came the jump from operating outside the heart to actually fixing heart disease. And that also has Canadian roots, with a guy named Wilfred Bigelow, who found that hypothermia, or cooling kids down, was a protective measure in terms of sustaining organ function when you operate on them. This is way in the days before the heart-lung bypass machine. So there were some operations performed, early operations performed just under hypothermia. And then came along Dr. Lillehei from Minnesota. And Dr. Lillehei was really the father of open heart surgery. He was really the one that pushed it along in the 1950s. And it was like the arms race in the 1950s when it came to congenital heart surgery. Every surgeon was trying to get ahead of the game and trying to figure out a way to operate inside the human heart. And I don't know how many of you heard of this, but this is how Dr. Lillehei started the whole deal, with cross circulation. So when they say parents are important for their kids in congenital heart disease, it started at the beginning. Because what happened was there was no heart-lung machine, but the heart-lung machine was the parent. So two people would be wheeled into the operating room, the parent and the child, and the parent would get hooked up, the parent's blood vessels would get hooked up to the kid's heart, and the parent would act as the heart-lung machine for the child. This is the gory slide. So this is the first operation. Gregory Glidden was the patient. He was a 4-year-old with a ventricular septal defect, and Lyman Glidden was the father. And this is the first cross-circulation operation. And Gregory survived the operation. He died 18 days later. And there was about a 50% mortality rate in the first 25 kids that were operated on with cross-circulation. But that really pushed the science drastically. And finally, a heart-lung machine was invented around 1955. That's what it looks like today. And that's what's made this possible, where surgeons like me could operate on a bloodless, motionless field and make it look easy compared to the way it was done way back when. And now we're to the stage where congenital heart disease, most of it can be fixed, and not just fixed, kids can do really well and have normal lives. And unmute yourself if you know who this is. Anybody? So this is Shaun White, who won the gold medal in 2010 in Vancouver in snowboarding. And Shaun White's on this slide because he was born with tetralogy Fallot. So it completes the story. He's had 2 operations so far. And so when parents ask me, can my kid grow up and do everything they want? And when I say they can win a gold medal in the Olympics, it's true. It's not just hyperbole. So that's that. And I'll stop sharing. And if anybody has any questions about any of that, I know I went super fast, but I again wanted to save time for all of your questions. So you can chime in anytime you want. You can just unmute yourself or raise your hand. And if I'll give it a minute or two, if not, I'll start answering all the questions that were submitted beforehand.
And you can leave questions in the chat if that's easier, if you're, wrangling bedtime or whatever else is going on, that's fine as well. Of course, we have a number of questions that everyone submitted, so we'll start going through those in a moment.
So there's a lot of questions. So Tony and I have divided the questions up into sections, and I'm not going to be able to go back and forth between question and figure out who asked them. So if you're the one that asked them and you want to ask a follow-up, or I didn't answer it adequately enough or whatever, just chime in. Like this is intended to be a conversation, not just me talking the whole time. So anyhow, the first question has to do with parent involvement and transition to adult care. So the first question are, what are some questions parents should ask when deciding on which surgeon or hospital would be best for their child's operation? What rights do we have as parents to discuss who performs surgery on our children? And more generally, how should we advocate for our child? And I chose that question first because I think it's a perfect introductory question. And it's one that it's most difficult to navigate, especially in the healthcare environment that we have today, where oftentimes parents go in and they feel intimidated by first the disease that they've just been handed, and then all these professionals that are using words that they don't understand, and they don't want to piss off their doctor. But I think it's really important, especially when your kid's undergoing heart surgery, to make sure that the people that are doing the heart operation, not just the surgeon, but the whole team, is experienced, especially when it's not, I hate to use the word straightforward, but when it's anything more than straightforward heart operations. So I think it's really important to honestly ask them how much experience they've had, what the results are like, and honestly ask them, about the list of complications that can occur, just so that you're fully informed on what the possibilities are. I always tried to list all the complications up and including death, but tempered it such that, you have to list all those things. That doesn't mean any of them are going to happen, but if parents don't understand it, then you really haven't given them informed consent. Parents have every right in the world to decide who does an operation on their child. Having said that, it's a little bit difficult with congenital heart surgery because it's not like your kid's getting a hernia fixed and there's 15 surgeons to choose from. There's only a few to choose from in Canada, even less in British Columbia, and less in Western Canada. So, but you certainly have a right to have a say in it. I don't know how cases are allocated now at BC Children's. I know how they were allocated when I was there, but you have a right to ask what your options are, and you have a right to advocate for who you think is best handled to perform that operation. I think the parents are the consumers in all of this, and the consumers are always right. So you should do whatever you have to do to advocate for your kid. The next question, unless somebody has a follow-up on any of that, the next question is, should parents listen in when the doctors are rounding on their child and ask questions? What questions should they ask? And how much detail should a parent know about their child's meds, blood work, etc. during their stay in the hospital? And what should and shouldn't they be asking about? Well, I think it's very important for parents to be on rounds if they're able to be. Obviously, there are parents that have other commitments and other children, and and usually it's left on the mom, and the dad's often working and all the rest of it. So sometimes it's not possible. But if it's possible, I think it's really important for parents to be on rounds when the team is making rounds, and to ask whatever questions they think are necessary to understand the plan for the day. And oftentimes, I think parents get a bit intimidated by the conversation that happens during rounds, because it can be medical and technical and go over their head, and they don't want to appear ignorant about the questions they ask. And I don't think there's ever a fear of that. Like, I think you should understand what the team thinks about your kid for the day and what the plan is for the day. And there were times when the question involved an answer that was too long to address on rounds, and I would just come back after rounds and deal with it one-on-one with mom or dad, and tell them I'd come back after rounds to talk to them. So I think you should be fully aware of what's going on in the hospital. Nobody likes to talk about it, but there's, there are plenty of things that can go wrong during a hospital stay. They're not egregious mistakes in the sense that nobody intends to make them, and nobody's doing it with harm intended, but it's just the reality of the world we live in today. So I think you have to take as much role in the care of your kid as you possibly can, understanding the limitations of dealing with the rest of your family. Does that answer that question?
Jen has one question, I think.
Yeah.
Right, Jen.
I was just going to comment to that. So we're from Manitoba, and our son's surgeries ended up in Edmonton and in Vancouver. So we had experience at two different heart centers. And in Edmonton, when we just started our journey, one of the intensivists during rounds kept asking us what our opinion was on how our kid was doing that day. And he was 9 days old or 10 days old. I was new into this heart journey and I had no clue. And I felt like super out of depth to even answer that. But I was so thankful that they asked us that question, because it gave us voice for the rest of the journey with our son to be able to give our own perspective. Not that we were telling doctors what to do, but our instinct as parents have something unique that the doctors and the nurses and the specialists don't have, that sort of like heartbeat on our kids. And yeah, I found rounds so very helpful for just navigating even the different centers, having gone through different treatments in different places. It was in our heads and we had an idea what had happened because we had attended those rounds, which helped us advocate for our child better the second time around as well.
Yeah, thank you, Jen. And for all of you that don't know, Jen's written a book about her journey and about parents and navigating congenital heart disease. Jen, if you want to put it in the chat and people can look it up, it's a great book. I suggest that you read it. It's a very easy read and very well written. We have a couple of authors. I'll mention some of them later. So the next question is,
could I just add to that, Dr.
Yeah,
Gandhi?
please.
I just want to add that it helps healthcare professionals, like if you guys are in rounds, helps us provide family-centered care and helps us understand your emotions, because we're the medical professionals taking care of your children, but it also helps to understand what you're going through too. I think it's important to ask us to simplify any medical terms that you don't understand. I think that's really important. And then understanding like the medication that your kids are on and maybe what drug interactions, or just asking questions, because the more questions you ask, the better understanding you have of the whole situation that's going on, because it can be very complex with your kiddos.
Thank you. Nicole, is that Nicole from the ICU, Nicole?
Emergency, but yeah, I've been on both sides because I don't have a kiddo who has a congenital defect, but I was in the NICU, and being on both sides, I got to see and understand what families can go through, and then me giving a report or during rounds just helps me understand what families are going through when they're listening in and asking important questions.
Yeah, I think it's also important to be present, to connect your kid with the doctors as much as possible. As much as I hate to say it, sometimes these kids are labeled according to their diagnosis, and I think we really need to, as medical professionals, need to do a better job
You still have a rate for slower than
understanding
homeless.
the humanity behind it all, and
Mhm.
the
No,
children,
no.
their parents, the journey.
First
that
of all,
they
everybody
had.
knows who you are. This is a
Basic-
formality. The database is like sort of Play-Doh.
I'll just mute.
You can mute people, yeah.
Yeah. Anyway. Okay, so the next question, what signs should parents look for to know when additional surgery might be required in a child who's had heart surgery as a baby and is now a teenager? Well, that's a very broad question because it really depends on the diagnosis. There's some heart defects that are fixed with one operation, and there's very little worry that you should have for the rest of your child's life. But there are a lot of other ones that clearly it's a work in progress for the kid's whole life into adulthood. And it really depends on the diagnosis. But generally speaking, the symptoms of heart failure are what you really need to look at. Now, heart failure can be two things. When people say heart failure, they think, okay, the heart's failing, it's not working well. When I say heart failure, I mean congestive heart failure in the sense that blood's backing up into the lungs because there's a leaky valve, because the contractility or the squeeze of the heart's not doing well, because there's a hole that's gotten bigger inside the heart, et cetera, et cetera. So in babies, they fail to thrive, meaning they don't grow well, they don't eat well. In older children, they have exercise intolerance, their breathing gets more labored, and they start developing swelling in areas of their body. So all those general symptoms can be a sign that the heart's not working well. Frankly, if there's anything going wrong in a kid that has heart disease later in life that's not explained by a simple respiratory virus or something that goes away within a few days, you always have to have the heart in the back of your mind as something that's going on attached to whatever the original diagnosis was, which is why a lot of these kids, if not all of them, are followed lifelong for their heart defects, short of ones that have simple holes that are fixed early on and never have to be followed again.
Dr. Gandhi, there's one question in the chat. I don't know if
Oh.
you can see it or if you want me to read it out. From Kripal.
Our daughter's graduated the Patch Clinic, and our first appointment is coming up in a couple of weeks. Have you visited the Patch Clinic? You did one of the operations on our daughter. Yes, so the next question is, how can parents prepare and advocate for their children's transition from pediatric to adult care, ensuring they continue to receive comprehensive care and prevent being lost to follow-up? So this is a very important question. And yes, I not only visited the Patch Clinic, I worked at St. Paul's up until 2017. So I was an active member of the team. The problem is that the concept of a team in the adult world and the concept of a team in the pediatric world are not necessarily identical. They're not identical. So your kids will have all grown up in a children's hospital, getting taken care of by children's specialists who have a completely different mindset than the adult world. I don't know how many of you yourselves have been patients in the adult world, but it's night and day compared to the pediatric world. And yes, when your kids become of age, they get to make their own healthcare decisions, and doctors and nurses talk to them directly and not through you, but that doesn't mean you shouldn't be involved and be an active part of their care. And many of your children will want that and almost demand that because they're not used to making those sorts of decisions and being the sole participants in their care because they've not experienced that their entire lives. So I think it's really important from the get-go when you transition to the world of adult medicine to insert yourself as you feel is necessary, giving your kids the space that they want, but also to make sure that the care providers know that you're there and want to be communicated with. I mean, I have 3 children, none of them have heart disease, but you know, my oldest had shoulder surgery, I don't know, a year or 2 ago, and I found it very difficult to get any information on the day of his operation I was left out hanging. His operation was supposed to be done at 1 PM. It wasn't done until 7 p.m. Like, I was worried sick. And nobody would tell me anything. And so I think it's really important from the get-go to try to insert yourself as much as you feel is necessary and as much as your children want you to, because they're still your children, no matter if they're 5 or 15 or 25 or 35. And honestly, that transition from childhood to adulthood results in a significant amount of morbidity in some children, because kids that still require attention, still require medicine, when they turn into teenagers and young adults, they become invincible, and it's a very vulnerable time period. We see it especially in the transplant community when they stop taking their immunosuppressive medications, and there's a huge attrition rate, meaning kids actually die when they transition from pediatric care to adult care, just because the follow-up is not what it should have been, or what it was like, I should say, in the pediatric world.
Dr. Gandhi, it's Debbie with the Children's Organ Transplant Society. Thank you for that. That's great information. What I'm seeing is that a lot information, especially for children that are moving over from BC Children's or whatever into adult care, often have other learning disabilities or other disabilities that need to really be noted on the charts that are moving over from BC Children's over into the adult care, so that the doctors that are taking care of our kids really understand more than not just the medical challenges that these young people have, but also the other challenges. And it's being completely lost in transition. I hear about it all the time. And you and I have spoken, and I know that, that kids that or some young adults are crashing. They're literally crashing from medical trauma in their early 20s, of which mental health maybe issues have not been dealt with when they're in their teens, so that is not so profound. And when they're crashing, then they really need parent involvement or somebody's involvement to help them through the system.
Yeah. And I think it's important to recognize too that this is such an evolving area, because as of 2010, the world now has more patients with adult congenital heart disease than children with congenital heart disease, obviously due to the success of heart surgery over the last few decades. So it's a growing problem, because we don't really have, or a lot of places don't really have, good continuity between the pediatric and the adult world. And a lot of the specialty services, like Debbie talked about, that are readily available in the pediatric world or almost routine in the pediatric world, don't exist in the adult world. Even for things like syndrome, like trisomy 21 or Down syndrome, like they just don't have that stuff in the adult world to the extent that it exists in the pediatric world. Jen asked a question, is there a too young age to include your kids in their healthcare? That's a great question. And no, there isn't. And I don't know what the right age is. When I've thought about this before, I kind of think if they're young enough to have a phone, then they should be involved in their healthcare. And I don't know what you guys all do. My magic number turned into 13 for when my kids got phones. That wasn't necessarily my decision, but nonetheless, it was that was the number that we arrived on. I don't know what it is nowadays, but I think if they're able to surf the internet and find out information, then they should have that information about their own heart and understand what's going on inside their body and be involved in their care. And that will certainly make it easier. The younger you get them involved, it'll make it easier to transition them into adult world with a congenital heart. Let's ask, is there too young age to get them mental health supports? No, I think that's also an excellent point. The problem is getting them mental health supports. Like, I think they need mental health supports as early as they can get them, but you probably know better than I how difficult it is to access that support, especially in this province. So often it has to be done privately, and doing it through a pediatric hospital sometimes is very difficult. So, but I don't think there's ever a too young.
I'm just wondering, like 7 years ago, I remember having some questions about what Canada is doing to supply more doctors for the adult world to deal with congenital heart defects. Where are we at in that? Like, do we have sufficient doctors right now who understand CHD? I've compared it to people like if you have a Volvo, you want to go to a European mechanic so that it gets fixed proper and not just take them to like the Dodge dealership down the road. And when a kid's born with a heart defect, their heart is different. It's not quite the same as other adult heart surgeries that happen. So yeah, where are we at in actually having choices of doctors who know what to do with our kids when they're adults?
There's a lot of Dodge dealerships, and there's not many Volvos or Ferraris out there. That's the problem, honestly. That was my frustration with the adult congenital world, was when I said that the teams aren't the same. That was a kind way of saying that, you know, if I talked about pathophysiology of congenital heart disease in the adult world, very few people understood what I was talking about. Like some of the cardiologists would, but the anesthesiologists wouldn't. Some of the ICU nurses wouldn't. The ward nurses wouldn't. Those places are factories for acquired heart disease, valves and coronaries, and they do a fantastic job with that. But congenital heart disease, with rare exception of institution, is not that well addressed. And even the providers that are tasked to address it don't have a lot of formal pediatric training. They have training in adult congenital heart disease, but to me, that's the problem. Like, to become a pediatric heart surgeon, I was an adult heart surgeon first, and then a pediatric heart surgeon, then did pediatric training. To be an adult congenital heart surgeon, there's no pediatric training involved in any of that. So to me, that makes it somewhat difficult, except for the institutions that have recognized that. In Toronto, when I was there, which was now 25 years ago, they had a very well-oiled machine in terms of the adult congenital heart center at the Toronto General Hospital. But Dr. Williams, who was the boss at the time, he was pretty dictatorial, and he made it that way. Like, there were only certain nurses that could take care of the patients. There were only certain doctors that could see the patients, and only certain anesthesiologists that could put the patients to sleep. And I think that's really what's necessary. And hopefully that will evolve in more institutions as time goes on. It almost has to, because it's such a super specialized area that you, like you said, you can't just take your car into anywhere. If your car is a European car, you just can't take it into the Dodge dealership. It's just not going to work. But the doctor problem in Canada is widespread beyond this. I don't think we're anywhere near to fixing this one.
So then I hear that advocacy becomes even more important as our
Yes.
kids go into the adult system.
Oh yes, absolutely, 100%. Okay, so the next set of questions are a bit more specific about certain disorders. So again, if whoever asked the question wants to chime in or ask a follow-up or seek clarification if I don't answer it correctly or fully enough, let me know. So the first question is, do children born with pulmonary atresia intact ventricular septum that have had a biventricular repair eventually need a pulmonary valve? If yes, how do you decide when's the best time to place a pulmonary valve? And can surgeons do this in the cath lab, or does it require open heart surgery? So just to get everybody on the same page, pulmonary atresia intact ventricular septum means that kids are born without a pulmonary valve, and they don't have any connection between the right ventricle and the lungs. And some of those kids are born with a very small right side, so they go down the single ventricle pathway. And some of them are born with a relatively normal right side, so they go down the biventricular pathway, meaning they get a patch in their right ventricular outflow tract and closure of the hole in between the two upper chambers, the ASD. But they don't usually have a functional pulmonary valve early on. So many of them, yes, do need a pulmonary valve as they're older. And the thinking has evolved quite a bit on this over the years. It used to be that we waited for those kids to get symptomatic, but it turns out that that's actually waiting too long. If you wait for kids to get symptomatic or for them to get sick, you've probably you're probably behind the 8 ball. So what's done now usually is serial MRI evaluations to evaluate how big the right ventricle has become or how dilated it's become. And it gets dilated because when there's no pulmonary valve, there's free leakage of blood to and fro across the right ventricular outflow tract, or from the right ventricle to the lungs and back. And so the more dilated the right ventricle gets, the more there is a necessity to put a pulmonary valve in. And now there's like a number. They measure a number called the right ventricular end diastolic index on MRI. And when that number hits 150, it's time to get a pulmonary valve. So it's gotten pretty scientific as far as that goes. Now, whether or not that valve can be replaced in the cath lab or needs an operation really depends on the anatomy. So if it's a first-time pulmonary valve, it almost always needs surgery. If the kid's already had a pulmonary valve, then oftentimes another valve can be put in through the existing valve called a valve-in-valve procedure, and that can be done in the cath lab. That's still relatively new technology, so don't let anybody let you think that that's going to last forever. It's not, but it's a measure by which to buy time and avoid an operation. For children born with a single ventricle heart, how do you determine the need and timing for a Fontan operation? Example, single ventricle with SATs of 85 or 90% after the Glenn. When is the Fontan needed? And how do you prevent failure after the Fontan? Well, those are all very good and complicated questions. So a single ventricle heart means that you're born with one effective pumping chamber instead of two, which a lot of your kids probably have. There's a whole bunch of different types of those, but they all go down a pathway that ends with the Fontan operation. And the Fontan operation is the end result of diverting all the blood. It's supposed to come back to the right side of the heart and get pumped to the lungs. You take all that blood and you drain it directly into the lungs. So those two big veins that drain blood from the upper and lower parts of the body, instead of going to a ventricle to get pumped to the lungs, they get attached directly to the lung arteries. And then the one ventricle that the kid has pumps blood to the body. And the Fontan is the last in the series of those operations where the lower blood vessel or the inferior vena cava or the IVC gets attached to the lung arteries. The need to do it depends on the child's situation. So it depends on the child's oxygen saturations. The only thing a Fontan does after a kid's had a Glenn, which is step 2, is make your SATs go higher. So if the SATs aren't a problem, then there's no rush. Having said that, you don't want to wait forever because it does get more complicated if kids get really old meaning like in their teenage years. You don't want to wait that long. But there's no rush to do it at 2 or 3 or 4 or 5 years of age if the kid's SATs are fine. So it really depends on a lot of clinical evaluation, mainly the oxygen saturations. How to prevent Fontan failure is $1 million question. If I knew the answer to that, I'd probably won the Nobel Prize by now. But the main things to prevent Fontan failure are evaluating the kid's anatomy and physiology before the Fontan. So the thing that predicts Fontan failure the most is problems that make the kid not a good Fontan candidate. So there's a list of like 10 or 11 things that cardiologists and surgeons are supposed to check for before their Fontan based on their echo and their cath and other investigations. Check off all the boxes. Are all these boxes okay? Then the kid's a good candidate for the Fontan operation. If some of the boxes are okay and some of them aren't, and the kid's a bit of a higher risk, then you do what's called a fenestrated Fontan, meaning you put a hole in between the Fontan and the heart so that the oxygen numbers don't go fully normal yet. They just go a little bit higher and then you can close the fenestration later. So it's like a 2-step Fontan, but it protects against early Fontan failure. Late Fontan failure is one of those things that is a bit of an enigma. Again, preoperative risk factors are the most important things, but there are some kids that have no preoperative risk factors that 20 or 30 or 40 years down the line have Fontan failure. Again, having said that, the Fontan operation is now about 40 years old. So we have kids that are of that age, 40, 50 years old. And those kids are kids that had the early versions of the Fontan operation, which are not nearly as good as the as the modern versions of the Fontan operation. And so kids can live a long time without failing Fontans, even having operations that are now quite outdated. My kid has neck retractions in an unrepaired, and it has an unrepaired small to moderate VSD and is 14 months old. Is this common, and does it need more investigation? No other symptoms. Well, neck retractions are always a bit of a worrisome sign because they mean that your child is having a little bit of a harder time breathing. Normally, breathing should be an effortless event. You shouldn't notice somebody breathing. If they're using what's called accessory muscles, so muscles other than the normal respiratory muscles, meaning muscles in the neck, their diaphragm, their intercostal muscles, which are those muscles between the ribs. If the ribs suck in when they breathe, that means they need extra help to make the same respiratory effort than a normal person would. So yes, probably more evaluation is necessary to figure out whether that VSD is causing enough of an impact that it needs to be addressed. What are general care considerations for children with conditions like unrepaired VSD, and how can parents recognize signs that additional surgery might be needed as their child grows? Well, that's also a good question. So VSDs are a tricky one because, first of all, VSDs are the most common heart defect. A VSD is a hole in between the left ventricle and the right ventricle. There's 4 different types. And of all the VSDs that occur, 50% of them close on their own. So 50% of them don't need heart surgery, but the other 50% of them do. Now, in the category of those that don't need surgery, some of them don't need surgery because they completely close on their own, and some of them don't need surgery because they've gotten small enough that they don't cause a problem significant enough to warrant surgery early on, meaning congestive heart failure, like failure to thrive, growth problems, feeding problems, sweating with feeding, all that stuff that means the kid's not doing well because there's too much blood going through that hole. If the VSD is small enough, it doesn't cause that kind of impact and it doesn't need to be closed. That doesn't mean it can't cause a problem later in life. In fact, some of those small VSDs can cause bigger problems later in life because small VSDs can result in turbulent blood flow in the heart. And turbulent blood flow can lead to other problems like extra muscle growing, like infections called endocarditis of the VSD itself or of heart valves. And so that's why the earlier question about what should we look for later in life is important, especially if you have an unrepaired VSD, because anything that goes on later in life that might be a bit out of the ordinary could be because there's consequences of having not repaired that child's ventricular septal defect early on. So I think that's something to look out for. It's unlikely that a small VSD, almost impossible that a small VSD is going to get bigger and cause congestive heart failure later in life. It's usually going to result in other problems. Here's some very specific questions that I think probably some of them come from the state of New York. Can you discuss the pros and cons of the PAIRS procedure, especially for neonatal Marfan syndrome? So for those of you that don't know, Marfan syndrome is a disease that affects the connective tissue of the body, and the heart's one of the main organs that's often involved. And one of the things that's most commonly involved in kids with Marfan syndrome is the aorta. So the big blood vessel that comes off the left ventricle and supplies blood to the body. And what happens to the aorta is that it gets dilated or enlarged, and these kids get aortic aneurysms that can kill them. They can either rupture, so they burst, or they can dissect. Dissect means that they develop a tear on the inside lining of the blood vessel. So the standard therapy for those, when they reach a certain threshold size, is to replace the aortic root. Now, that means you replace the base of the aorta, which is usually what's involved, and that's a complex operation. There's 2 ways to do it. One is you take out the whole aortic root, the aortic valve, the whole 9 yards. You cut away the coronary arteries, which are the arteries that supply blood flow to the heart muscle. You replace all that, with what's called a composite prosthesis, which is a prosthetic aorta that has a valve built in, a metal valve, and then you reattach the coronary arteries to that composite prosthesis. That's called a Bentall operation. But some kids don't need that because their valves are completely fine, and you don't want to ever throw away a good valve. So there's another operation that's been done for the last 20 years called a valve-sparing aortic root replacement, which is the operation I always did for Marfan's kids, which is you cut out everything I just said except for the valve, and it's a much more technically complicated operation because you have to save the valve and do a bunch of stuff to save the valve. But anyway, you replace everything except the valve. It's still a big operation. This PAIRS business it stands for Personalized External Aortic Root Support. And what it is kids get a CT scan of their chest and they get this model made of their own aortic root. And based on that model, a mesh is created to form fit their own aorta. And surgeons then go in and wrap their aorta with this mesh. They don't take anything out. They leave everything in, and they just wrap the aorta with this mesh. And this mesh is supposed to grow into the aortic wall and reinforce the integrity of the aorta and prevent it from dilating or dissecting. Now, I'll be honest, I've never done that. To me, it seems like cutting a dandelion off at its root or cutting the dandelion off at its head and not taking the root of the problem out, and it leaves the diseased aorta in place. The results for the PAIRS operation, at least the published results, are pretty decent, but they're short term and they're mostly adult results. So I think it's hard to extrapolate those results to the pediatric population. Conceptually, I have a bit of a problem with it, again, because it leaves diseased tissue in place, and because most of the times when surgeons come up with easier ways to do things, and this is way easier because you don't have to go in a heart-lung machine, you don't have to stop the heart, you don't have to cut anything out. You just you're wrapping a sweater around the aorta and sewing it in place. When surgeons come up with stuff like that, it's because the standard operation is hard, it's difficult, it's technically challenging. So if it was my kid, I'd find some good surgeon that knows how to do a valve-sparing aortic root replacement and get it done. But I will put the caveat in there that I've never done this PAIRS business, and the results in the adult population, at least the short-term results, are decent.
So Dr. Gandhi, I think you think that came from NIMI, but it didn't. Is there somebody else in New York who has a kid with Marfan that's on here?
I have a friend whose family has that prevalent in their family, and I told her about this. I just texted her. I'm like, "Are you on?" Because I don't see her name, but maybe she sent in the question.
There were 2 PAIRS questions, so I thought they came from. I knew it didn't come from you, Barbara, but I thought maybe it came from one of your friends. Anyway,
I was just going to say that if she wants any information about New York surgeons or doctors, that she could totally connect with me.
Yeah. Okay.
I don't know.
Thank you.
I do
sure
have
she
the
would
name
love
of
that.
that person. I can maybe connect. I'll give Dr. Gandhi the information. If he feels appropriate, he can connect you guys.
Yeah.
Okay.
I mean, even if they don't live in New York, Barbara knows every surgeon on the planet. So
That's funny.
So there's a question on the chat. In your opinion, who in Canada would be the most qualified surgeon to perform a Ross procedure? There was a discussion last year from Jackson's new team. It might be an option for him. They ended up doing another aortic resection, which appears to be holding well at this time. But in case we wind down the same road again, someone I'd like to know who's the most qualified, considering Jackson's complexity. Thanks for the question, Rachel. Yeah, that's a good one. There in Vancouver, I don't really know, to be honest, because I was really the only one that did the Ross procedure back then. I mean, I'm sure the surgeons at BC Children's also do them now. I don't know what their level of experience is. I think that there's a couple of surgeons in Toronto that have a lot of experience with the Ross operation. Toronto in general has a lot of experience with the Ross operation. It's sort of one of the birthplaces of the Ross operation in Canada because of Tyrone David, who popularized the operation. And certainly if Jackson became of adult size, it wouldn't be inappropriate to find a surgeon in Toronto that does the adult form of the Ross operation to do it, if it was just that. But it's not an operation that a lot of people like to do because of its technical complexity. So you'd really have to probe the surgeon that was doing it to make sure they had a lot of experience. A Ross operation, again, for those of you that don't know, is an aortic valve replacement in kids, but instead of putting in a mechanical valve or a tissue valve from an animal, you take the kid's own pulmonary valve, so the valve that connects the right ventricle to the lungs, you cut it out and you use that as the tissue to replace the aortic valve, and then you replace the pulmonary valve with what's called a homograft or a cadaver valve from a human being, and then you have to cut out the coronaries and reimplant them, and it's magnitudes more difficult than just sewing in a mechanical valve, but there's not a lot of people that do it. Okay, let me say, I'm going to skip a few because I know I don't want to keep you guys here all night. There's one that came in today about in utero diagnosis. The question was, how frequently does congenital heart disease get diagnosed in utero? How often is it missed? So that's a function of the healthcare system. So when I was in the United States, it was routine for these things to get missed. They got missed all the time. In fact, my practice was way different south of the border because we often didn't get notice that kids were being born with a heart defect because prenatal testing was not nearly as good as it is in Canada, and things just didn't get picked up. In British Columbia, it was the exact opposite. It was very rare to get a surprise. We got them, and they were really isolated for the most part to certain diagnoses which are almost impossible to make in utero. Like there's one diagnosis called total anomalous pulmonary venous drainage, where the veins that drain the blood from the lungs back to the heart, that connection doesn't happen the way it should. And that diagnosis is almost impossible to make in utero because of the way the circulation is in utero, because babies don't use their lungs in utero. And that diagnosis is almost always made after the babies are born. But other than that, the vast majority of diagnoses are made in utero at the 20-week ultrasound. There's a couple of ultrasound places in the province, I won't name them because I probably shouldn't, but there's a couple of ultrasound places in the province that aren't that good, that routinely miss stuff. But other than those, and maybe those problems have been worked out in the last year and a half, but other than those, it's excellent in British Columbia. And so I think most things should be picked up in utero. So what normally happens though is the 20-week ultrasound is your screening ultrasound, and it's just a regular obstetrical ultrasound. And then if the ultrasonographer sees something, then they refer you to the cardiac clinic where you get a detailed cardiac ultrasound, unless you're a mom of a kid that's had congenital heart disease. So your chances of having another baby with congenital heart disease are still low, but they're much higher than the general population. So congenital heart disease, like I told you, is 1 in 100. If you've had a kid with a heart problem, then your risk goes up to 4 in 100. So then if you're pregnant again, you should automatically get the cardiac focused ultrasound at 20 weeks. There should be no questions asked. Let's see, the next question. Well, it says somebody on the line, I don't know if they want to identify themselves, wants to become a pediatric heart doctor, passionate about working with children. What does the education and training pathway look like? Well, I'll sum it up. Long, really long. So undergrad 4 years, med school 4 years. Back in my day, you had to do full general surgery residency, which was 5 or 6 years, and then a cardiac fellowship, which were 2 or 3 years, and then pediatrics, which was another year or 2, depending on which. So, add all that up, it's a lot of years. There's a lot of years that you don't make any money. And so it's a lot of commitment. Having said that, it was the greatest job in the world. It still is the greatest job in the world. And the most important part about this person's question is the word passionate. And so what I always told trainees is that if they had a passion for taking care of children, whether it be pediatric cardiology or pediatric heart surgery or whatever, if that passion was just overwhelming, then go for it. If it's not, then don't. So especially on the surgical trainees, like I told them, if you can look at yourself and consider yourself being happy the rest of your life, doing coronary bypass surgery and doing valve replacements in 60, 70, 80-year-old people, like more power to you. But if you're happy doing that, then that's what you should do. If you're not going to be happy doing that, which was the situation for me, I would have been bored out of my mind, then you should do pediatrics. So I think you should go for it if you have a passion, but it means a fair bit of commitment for, I think, Tony, I'll stop it there. There's like 4 or 5 more questions, but again, I don't want to keep everybody all night. So if anybody has any other questions, I'm more than happy to answer them. I'm also happy to take any feedback, good or bad, about whether this was useful or not, whether we should do it again. This is all just a bit of a project to figure out how I can be of assistance in moving forward.
Was that helpful, anyone?
Yes, thank you, Dr. Gandhi. We appreciate your time.
Thank you so much.
Quite welcome.
Great.
Awesome. Yeah. So as some next steps and follow-ups, of course, I'll get the recording out to everybody probably tomorrow at this point. If we feel like there's interest in a follow-up one, certainly I'll leave a method so that you guys can kind of leave some feedback. Maybe there's requests on specific topics that you want to touch on. Maybe you want to reach out to Dr. Gandhi directly. Either way, I'll maybe give some methods for you guys to sort of take some next steps on that. And if this has been helpful, we're happy to do another one of these in, a couple weeks, couple months, whatever works time frame wise. But appreciate everyone taking the time to jump in, especially this late at night. So thank you.
And if it has been helpful, spread the word through whatever means people spread the word these days.
How can people best stay in touch with you, Dr. Gandhi?
Well, I'm on Twitter. You can direct message me on Twitter. I reopened my Instagram account today, so you can direct message me on Instagram. I think probably those are the easiest ways.
Great. That works. So we'll leave it there. Thanks everyone for taking the time. I appreciate it. And maybe we'll see you again soon.
Okay. Take care, everybody. Good night.